Welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me today is Pavlos Gkikas. Pavlos is a doctor of physical therapy, and just like me, he treats a lot of patients who have had ACL injuries, ACL surgery, and today we talk about AMI. So what is AMI? How does it kind of come about and develop after injury and after surgery, what we can do as PTs to address it, and why we need to address it in the first place. We also talk a bit about what happens if you do not address AMI early on and apply that throughout the rehab. There's a lot of great information and insight in here relating to early stage ACL rehab to tackle the AMI, all the way up to some testing considerations such as torque to body weight ratio and so much more. Great episode. I know you're going to love it. Before you check this out, though, be sure to scroll down and check out Isophit, our Season 5 sponsor. They're my go-to for all things isometric strength training. Enjoy. Pavlos, welcome to the podcast. I'm super excited to work with you today, man. Thank you so much for being here.
Yeah, thanks for having me.
For people who might not be familiar with you, or maybe they haven't heard about all the incredible stuff you're doing there over in Bethesda, would you mind filling them in a little bit about who you are and your background that way?
Yeah, so my name is Pavlos Gkikas. I'm a sports physical therapist with True Sports PT. I am originally from Greece. Earned my undergrad from Queen Margaret University in the UK, and then I pursued a postgrad degree at University College London, where I had the opportunity to work, learn, and conduct research in one of the best orthopedic hospitals in Europe. Moved to the US in 2018. Worked as a strength and conditioning coach for about 3 years. And then when I got my license, transitioned to PT. And now I'm in Bethesda working with athletes, seeing a lot of ACL cases, shoulder labrum repairs and hip labrum repairs for reconstructions.
Yeah, no, that's awesome. That's awesome. And I think you have a really unique and interesting backstory there too, is a lot of the PTs that I talk with were kind of trained and brought up in the States, and you've got more of a broader perspective, I'll say. And we've seen that with individuals on the podcast like Borko in the past. And I always really like and appreciate the difference that kind of comes from some of these different PT type systems in other parts of the country. And it sounds like from what you said, you're really pretty much only seeing shoulder, hip, knee. I'm sure you probably get a couple other things on occasion, but it sounds like you're very highly specialized in those three areas, those common sports areas, in particular the ACL. And I think when it comes to the ACL in particular, I think at this point, a lot of people have heard of it. We try to review the mechanisms and that sort of thing on the podcast regularly, but say there's someone listening who hasn't seen an ACL injury or doesn't know how, the ligament gets injured in the first place. Would you mind just kind of breaking it down for them real quick on, how the ACL gets injured and what kind of sports that's common with?
Yeah, for sure. So most of the ACL injuries that we see are non-contact or happen with indirect contact during some sort of deceleration, landing, or change of direction activity. And what tears an ACL is a load that exceeds its failure threshold. There's no clear consensus in the literature about the mechanism of injury, but an ACL rupture is likely to occur as a result of a combination of tensile loads, shear, or torsional loading. Looking at video analysis studies, the most frequent intersegmental positioning that we see at the injury frame, usually where the athlete has an abducted hip, there's a knee valgus, slight knee flexion, the foot is planted and often externally rotated, and we have ipsilateral trunk tilt and contralateral rotation. So this is kind of the representation, the kinematic representation that we see. Interestingly, from recent research, we know that there might be a sensory prediction error. So usually there's a deceiving action from an opponent or a distraction that leads or triggers that positioning that we just described.
And I think it's interesting that you bring up the element of the trunk as well with that ipsilateral lean, because that's an element that's often missed in a lot of the traditional models of, ACL injury mechanism, for lack of a better way to put it. People talk about the foot pronation, they talk about the knee valgus or the hip internal rotation, but they kind of forget like just above the hip is a lot of really important structures that kind of play into it as well. So I think the trunk angulation piece is very important there. And obviously, once the ACL is injured, especially in the athletic population, I would say the majority of the cases end up getting ACL reconstruction surgery. I think that's probably the most common route for people to take. And from a graft standpoint, over here, I tend to see a ton of quad tendon grafts. I think that's like the most common thing I see. I have like one BTB and one hamstring graft right now. Does your caseload tend to look similar, or what kind of grafts do you typically see from people, see from surgeons and the patients that you're treating?
Yeah, I mean, I would say we see a lot of autografts because of the population that we see, of course. I think quad tendon grafts are becoming more and more popular. So I see a lot more quad tendon grafts nowadays compared to hamstring or patellar tendon.
I'm curious too, on the quad graft, do you typically see in your patients more of a vertical incision or a horizontal incision?
I see more of a horizontal incision,
Mhm.
I think, right now.
I've seen a lot more of the quad grafts getting that horizontal incision, and the main rationale for it, at least that I've been told, is there's a device now, I think it's called a Quad Pro, that you can pretty much just slide up under that
Mhm.
incision to harvest the tendon, so it's like less invasive and heals better in theory. But I don't know about you, but I've noticed a lot of these post ACL quad grafts come in really, really inhibited. Like they are not firing the quad hardly at all on day one. I think I've had one or two actually get an active heel pop, so active full range extension on day one, but the majority of the time I'm not getting that for at least a week and a half, just because of how hard it is for them to fire their quad early on. And I think that's something that needs to be discussed in more depth is, we have the concept of muscular inhibition following ACL injury and ACL surgery, and a lot of people aren't getting that firing quick enough or early enough, in my opinion. When it comes to that whole concept of AMI, would you mind just kind of breaking down what AMI is and why we need to start waging war on it early on?
Yeah, so arthrogenic muscle inhibition, or AMI, is a neurophysiological phenomenon that we observe after an ACL injury or an ACL reconstruction. It is thought to be a protective mechanism to limit force expression and safeguard the joint from further damage. So when an athlete experiences an ACL injury or has a reconstruction, which can be considered as trauma to the joint, because we have tissue dissection, the bone drilling, graft fixation, etc. The the quad goes to sleep. So essentially, joint injury results in an alteration in afferent information, so sensory information, due to inflammation, capsule distension, pain, and deafferentation secondary to mechanoreceptor damage, which can lead to reflexive inhibition of the alpha motor neurons and a reduction in the ability to activate them. And that's what we see in the clinic. We see that they can't contract their quad, right? But there are also changes that happen in the central nervous system level. The brain, and more specifically the somatosensory cortex, needs to adapt to this new joint environment. So the nervous system adapts by relying on other sensory stimuli like vision, or by increasing activation to cortical areas which are responsible for higher neurocognitive processing to optimize the motor control. At the muscle fiber and neuromuscular junction level, because of the disruption in alpha motor neuron activity, we we see a lack of neural signaling or lack of action potential propagation, which can lead to disruption in postsynaptic processes. And we see from animal studies that there are a lot of changes that happen. So we have issues with regulation of protein synthesis and breakdown. We have actin myosin cross-bridging issues, impairments in mitochondrial function that are related to fiber type transitions. So we see that the fiber type changes transitions to faster twitch. We have the satellite cell pool is depleted. Myostatin is upregulated, which is a protein that can inhibit hypertrophy or lead to atrophy. And the quality of the tissue is not the same. It's more fibrotic and there is more fat infiltration. We have this disruption in the motor neuron activity. We have this loss of action potentials. We have this disruption in postsynaptic processes that can trigger mitochondria to produce excess reactive oxygen species, which can lead to contractile damage and dysfunction. And that results in muscle atrophy and weakness that we see with our patients. So the muscle atrophy and weakness that we see is not like the atrophy that we see with disuse. It's a little different. And it goes back to the neural adaptations that we talked about.
Yeah, it sounds like the way you kind of explained it there, it's almost like a downward spiral effect, right? Like it starts with the neurological input to the muscle and then gets cascaded further by the physiological components as well. And I think that's why AMI is such a complex thing to wrap the head around, right? Like, a lot of people are like, well, why is it so hard for the quad to fire or engage? Or, even in some of these other graft choices like the hamstring graft, like there's still a ton of quad inhibition, even though we didn't even touch the extensor mechanism. And I think you really nailed, the neurological side of things, the physiological side of things. There's a lot more going on behind the scenes than just, oh, we just need to, just engage the quad. Like, no, it's the body is literally fighting you, trying to make sure you don't engage the quad as more of a protective, neural-driven response.
Yeah, 100%. It's more complex than we thought it was. And that might be the reason why some of the strategies that we used in the past haven't been working as well as the strategies that we have now.
Yeah, definitely. And you also hit on a key point there about, the overall tissue quality. Initially after surgery, it's not the best. We have to, allow healing time to occur and that sort of thing. Healing is important, but we still need to be getting people going early after surgery. I mean, probably within the first 24 hours if we can. I don't want to wait 2 to 3 weeks to see someone after ACL surgery. In 2 to 3 weeks, if they haven't fired their quad at all, if they haven't started like attempting a straight leg raise or something like that, like we're really in for an uphill battle. I think you're probably in the same camp, right? You're probably getting people in within a day or two if you can.
Yeah, usually it's a day or two. We want to see them immediately. Some doctors want us to wait a little bit more. So that's the other thing, trying to educate and talk with the doctors and make sure that they understand and they know what we're doing and why we are doing and why we want to see the patient day one or day two to start working on range of motion, start working on quad activation.
As we are saying there, the longer you wait to start that stuff, the harder it is to get the quad back. Are there any other factors that you've noticed really playing into the whole AMI concept or quad inhibition concept?
Going back to the mechanisms that we just discussed, trauma to other structures. So if we have a meniscus tear or other ligamentous injuries, usually people tend to have more effusion, which can lead to more severe type of AMI. Another factor is tourniquet time during surgery. I don't have a lot of research to back this up, and I've heard about this from Dr. Dries and Dr. Yoni Rosenblatt. But we know that surgery is very stressful to the body, and the body is not used to that amount of restriction to the circulatory system. So when the tourniquet is released, there's a rush of blood to the limb. That's called ischemia reperfusion, which brings a lot of reactive oxygen species and can lead to muscle damage. And that's one reason why I like seeing patients for prehab and use BFR before surgery. And I got this from Jess Ellis. He used a protocol, 60% limb occlusion. He does 5 sets of 5-minute duration with 3 minutes rest in between. And he does quad sets, SLR, you name it. But we can kind of train or condition the limb to that before they go into surgery. So that's another factor. I don't have any evidence on that. I think it makes sense. Another factor is femoral nerve blocks. They're associated with 50% quad strength deficits post-op. There are some prospective studies that have shown that adductor canal blocks can preserve quad strength, but the methods of strength measurement are very heterogeneous, so not sure about that. And then, like you said, time is one thing, right? And that's why we want to see them early on. And anecdotally, I would say quad tendon grafts, like you said before, more severe AMI. After that, patellar tendon grafts, which makes sense because we have the extension mechanism is compromised, right? So it kind of makes sense that we're going to see more with quad tendon grafts or patellar tendon grafts compared to hamstring.
Right. No, exactly. And I think you hit on so many amazing points there, Pavlos. And just to kind of recap them a little bit, you mentioned about the nerve block and how femoral nerve blocks in particular can really inhibit the quad. I've seen similar, research and similar conversations with surgeons, so much so that some surgeons aren't doing nerve blocks anymore. Now, I would imagine that would be a pretty painful thing for the patient to wake up to. If they aren't on some kind of pain modulating medication. So I'm not going to publicly endorse that because that's really going to hurt. However, I do see starting a shift from a few different surgeons and that sort of thing away from the nerve block, which I find interesting. On top of that, you brought up the BFR, which I think is absolutely essential pre-op and post-op. I mean, the whole concept of pre-op PT is huge. We want to get people stronger and get them in I call it the best shape of their life before surgery to make the recovery afterwards far better. You brought up the tourniquet time as well. And as you were talking, I just couldn't help but think about one of the patients that I worked with ended up seeing me for about 8 to 10 weeks pre-op, which is quite a long time. I don't usually get that. But we added, I believe, 3 or 4 centimeters in circumference to this individual's quads pre-op, like beefed them up. There's a lot of BFR, just a lot of high volume quad stuff, that sort of thing. Tourniquet time on surgery was almost 90 minutes, which is pretty long comparatively to some of these other ones I've seen. I've seen some in the 30s and 40s. But day one, heel pops, straight leg raises, all those things, even though the tourniquet time was significantly longer. So I do fully endorse the pre-op PT. I do fully endorse the BFR, and I want to get into that more later on. The other thing I'll say that I've noticed is a lot of people just heal differently, and a lot of people perceive pain differently. And there's some people that they come in and they've got like a 5 or 6 centimeter effusion compared to their non-op side. And then others with the same surgery only have a 2 or 2.5 centimeter. So it's just interesting how, and I don't know the intricate details as to why, but same procedure in different people's bodies react very differently to it from an edema standpoint. And then on top of that, how they perceive the pain afterwards. There's some people that are just, for lack of a better way to put it, absolute dogs, and they just push through everything. And then there's other people who come in like a 9 out of 10 pain and they're really hurting and down bad. And I'm not sure why that is, but again, I think the individual differences there certainly impact that post surgical quad activation, for lack of a better way to put it.
Yeah, I totally agree with you on that.
So kind of diving into the BFR piece a little bit more, because you brought that up, and that's something that I think is absolutely essential. I think that the BFR obviously has great utilization pre-op, but how about post-op? When do you like to go for the cuff? What pressures are you going with, and what role does the cuff play in, bringing that quad back to life?
I mean, we use BFR early on. I think there is research out there starting BFR as early as 1 or 2 weeks post-op. So we start pretty early on and always making sure that the incision is healing well, the incisions are healing well, and there are no issues there. Plus that there are no contraindications. In regards to AMI that we talked before, BFR doesn't directly address AMI, but there are a few studies that report less pain and effusion. So going back to the mechanism, that the use of BFR might be beneficial to an extent. We usually go from around 60% occlusion. We might go a little higher depending on the person, how they perceive it early on, because that's another piece. And that's another factor why I want to see the patient before the surgery so they can use the BFR, use the NMES, and then they know what to expect.
Do you have any time restriction on the BFR as far as like, are you throwing it on for an entire session, or are you just trying to do 15 to 20 minutes with it? How long are you spending with the cuff?
Yeah, early on, we might spend, like you said, like 15, 20 minutes. And then later in the rehab, I usually use it as a finisher. I don't have any clear cut like time restrictions. It's
Yeah.
usually around like 15 minutes.
Yep. Yeah, no, I kind of go something similar as well. I think there's a certain point in rehab where it's just like a green light to just start doing BFR leg extensions every single day. And I think that's another important piece here as well is like, as soon as we can flex comfortably on the edge of the table to get the knee like down probably 80-90 degrees, like I'm starting people with unweighted leg extensions very early on. And I know that traditionally that was something that was kind of, bashed, for lack of a better way to put it. But I think it's probably the best way we have to isolate the quad and actually isolate the quad from, a strengthening standpoint. It's very difficult to compensate in that position. And I think, at least from everything I've seen, it's safe to do unweighted leg extensions a week or two after ACL surgery.
It is 100% safe. And there is more research coming out about comparing people who do leg extensions and checking the laxity of the graft at 3, 6, 9 months out. There seems to be no issues with leg extensions even early on.
So no impact on graft laxity, yet we can fully isolate the quad and kind of bring the quad back a little bit stronger, a little bit quicker, which I think is huge, because a lot of these other strategies I've seen in past approaches, they kind of invite substitution or compensation. And if our main goal is to fight AMI, then we can't have those things, because the body's going to compensate in crazy, weird ways. People are going to use their glute, they're going to use their calf, they're going to use all these other muscle groups to try and not load the quad. So we kind of need to force the quad loading.
Yeah, 100%. And even with close kinetic chain exercises, like you said, trying to put constraints in place, trying to direct the stress to the tissues that we wanna load is key, especially early on.
How do you like to incorporate the constraints? What kind of cues do you like to use on the close chain side of things as far as getting the quad stronger and more isolated that way?
I just put them in positions usually that they can, for lack of better terms, like cheat. So they're going to have to use their quad to perform the task. We do a lot of like single leg, wall slides. We do a lot of split squat with their back against a rack or the wall, leg extensions, like you said, stuff like that.
And I like those, posteriorly positioned constraints to help reduce hip extension moment. I tend to have people push knee forward a lot too, and I'll use a lot of tactile cues to try and get the knee forward and keep the knee forward just for a little bit more tendon load. And I'm interested to hear your thoughts on this, but I tend to use a lot of isometric exercise and isometric training to try and get a little bit more load through the quad in particular. It's like if I can get them in a position that I know is going to load their quad and then I just have them hold it there, it tends to burn it. But we also get a little bit of a more tendon loading type of effect. And since we did have a tendon injury from surgery harvesting a piece of it, I seem to notice a lot of benefit from it. And I don't have a direct study looking at isometric versus non-isometric training in post ACL or that sort of thing, but I tend to see a pretty good response from it from myself clinically, I think.
Yeah, I do a similar thing. I like isometrics in the beginning, even leg extension isometrics at 90, 60 degrees. Depending on the graft, you might have to modify, right? So sometimes with patellar tendon grafts, we might go 45, 60 if they have a lot of pain or discomfort. For quad tendon grafts, I usually want to see them doing leg extension with the hips extended or more of a hip extension position to kind of load that rec fem and get load through the tissue. But yeah, we do a lot of like knee over toe stuff, like you mentioned, and we approach it, especially with the patellar tendon graft, like a tendon pathology, like you said, right? So if they have a lot of pain for 5 out of 10, we're not going to push it. We want to get the quads going for sure. With a quad graft, I use a lot of isometrics. I've found that sometimes approaching it like a tendinopathy might not be the best move. Like I see they usually have a lot of like graft side tenderness and pain. So I usually don't push them as much as the patellar tendon grafts.
I think that's an important piece as well is, modifying the angles you're using based on the graft site and harvest and understanding that certain positions are going to put more load through, say, the patellar tendon than other positions, and understanding that, hey, that might play a role in what you're doing in your PT standpoint from your PT interventions. I think that's huge. I also think that especially with these closed chain exercises, I really like to incorporate stim myself. I know traditionally, a lot of the early protocols that I've seen they tell you to use stim like only seated or only on a table, but I kind of like to break the mold a little bit and say, hey, like, we're going to do split squats back on the wall, but we're going to give you a little bit of a stim thing and you just kind of hit the button and you use that every rep you do. I've noticed a ton of benefit from that. How about you on the stim side of things? What are you using as far as stim incorporation into the clinic? And how do you kind of progress that from day one to, whenever you stop using the stim unit? Do you stop at like 3 out of 5 quad, or are you taking it the full 9 to 12 months?
Yeah, so great question. NMES is a very important tool that we have, especially early on, to counter the effects of AMI, right? I use stim from day one with patients. We start with heel pops, quad sets, straight leg raises, all that stuff. And then we progress, like you said, when they can get to 89 degrees of knee flexion at the edge of the table, I might put the stim and do some isometrics in different positions. I use it mostly with leg extension activities. I might use it with some close kinetic chain stuff that I do. To answer your second question, I usually use it until they hit about 80% symmetry. I might bring it back. It doesn't mean that okay, we're done with the stim at 3 months. Like I'm not gonna use it. Yeah.
No, I think you're absolutely right about that, Pavlos. I think the stim is essential, and I kind of like the utilization until 80% is hit. I've seen a lot of varied approaches with stim in the past where some people just use it a full 9 months. Some people use it until they can do like say 20 straight leg raises without lag, and so on that way. But I like the regular and frequent incorporation of that. As far as why NMES works, because there's a lot of different types of stim, and I feel like I tend to have to explain this to at least one or two people a month where, the NMES is different than TENS. It's different than the stim unit that you might have bought on Amazon at home. Why is the NMES so good at fighting AMI? And, off of that too, do you ever incorporate the NMES with the BFR for like a 2-for-1 combo, for lack of a better way to put it?
The NMES kind of circumvents the inhibited motor neurons, and that's why it's so good, especially early on, to help with AMI. I use it with BFR, like I said before, with straight leg raises, heel pops, all that stuff early on, and with leg extensions.
As far as like some of the different considerations with the stim, do you have any preferred pad placement? Do you like the huge 4-inch pads or like the smaller, like 1 or 2-inch pads? And are you kind of like resorting to a certain frequency or pulse width or anything like that? Or does that stuff not really matter as much?
In terms of the parameters that we use, we go with a pulse width of about 400 microseconds, pulse frequency 75 pulses per second. Higher pulse frequency correlates with higher force production, but also to pain and fatigue. So too low, you have no contraction, and too high, you have pain. So sometimes, depending on the patient, we might decrease the pulse frequency to about 50 hertz. On time, if we're talking about leg extensions and isometrics at 90 or 60, I do 12 seconds on time, 50 seconds off time, ramp 2 seconds. And we want to hit about 50% MVIC, or the maximum tolerable intensity for the patient, but it has to be pretty high. Increasing the numbers of stimulating electrodes, placement over motor points can minimize fatigue and patient discomfort and improve torque production. We use larger pads, 3x5 pads in the clinic. Also making sure that you have new moist pads with good skin contact is good, because you reduce the internal resistance, and you improve the likelihood that the constant is carried. Sometimes we might shave a little bit the hair if the patient has a lot of hair, just so we can get this placement to the contact with the skin.
Yeah, and the nice thing is if you're getting them in early enough after surgery, their leg's probably already shaved. So you don't have that issue in the first month or so anyways. But no, that's a great point. And, I think it's interesting too, because you can look at a lot of different NMES devices out there, and having the ability to take the pulse width up higher, and getting the frequency up into the 75 to 100 range, I think are both essential. There's some different NMES devices I've seen that are kind of like preset on those, and you can't actually adjust them. And it's like, the pulse frequency is stuck at 20. And it's like, well, that's all well and good, but that's not going to do nearly as much as I want it to for the person in front of me. So really having the ability to adjust to some of those higher levels, I think, is essential. I also like your point on adjusting pad placement and that sort of thing based on the person in front of you, because everyone kind of responds and reacts differently, kind of like we mentioned before, right? Like, you can have people who get the same surgery by the same surgeon, and their knee looks drastically different afterwards from like a swelling, edema, healing standpoint. Well, the same is true from a stim standpoint, is I can put the pads in the same spot on 3 different people, and all 3 of them are going to have a different reaction and response to it. So really, kind of finding what works best for the person in front of you. And I kind of say it like every patient becomes a case study, right? N equals 1. Yes, there's a lot of great research to help guide us, but ultimately we kind of have to individualize it to the person in front of us.
100%.
I also want to mention too, so we talked about BFR, we talked about NMES. There's a lot of other modalities out there. Are there any other ones that you're reaching for to help tackle quad inhibition early or even later on in the rehab process? Is there anything else that you really like the looks of?
Yeah, that's a great question. So based on the mechanism that I mentioned before, with AMI, I use three strategies. So the first one is described as this open and exploit strategy. So by utilizing different modalities, we try to remove the inhibition, open the motor neuron pool, and exploit the availability of the motor neurons. And for that, we use modalities like, cryotherapy, high sensory tense, and there is some evidence about vibration. The second strategy, you can think of that as diverting resources or sending help. And we use eccentric cross exercise. You can use biofeedback, EMG or visual. We don't have in the clinic, so I don't use that. Or antagonist fatigue. That's another strategy. And the third one is, and we talked about that, the NMES. So you kind of circumvent the inhibition, you work around it. In terms of the high sensory tense is one that I use. You can put tense for 10, 15 minutes, 20 minutes prior to exercise, and you want the frequency to be pretty high, 120 to 150. And the somatosensation produced by tense can reduce the inhibition by masking the inhibitory signals. So you get a better response. So you can put tense before and then do all the activation stuff with the patient when they come in. Another one that I use is cryotherapy. It seems to change the sensor input from the nociceptors and the thermoreceptors and increase the motor neuron pool excitability and the activation. Cryotherapy, ice for about 20 minutes gives us a therapeutic window of 60 minutes. So I have patients ice before they come in, and even behind the knee, because the capsule in the posterior aspect of the knee is reaching receptors, and that helps a lot. They can use that, they can do that at home or before they come to PT. So I think there are two very useful strategies to open that motor neuron pool before they come in, and then we can focus on other things when they come in.
Yeah, I like that strategy a lot. And, I know there's a lot of people out there who bash things like ice. But, ice really does a great job at getting swelling down and making people feel good. And after surgery, getting that swelling down so we can fire the quad, and reduce our pain, I'm all for it. So I fully endorse that. And it's funny because I've seen kind of like a split stance on that, where some people were fully against ice and some people were all for it. And now it's kind of like coming full circle, I feel. And that's an area too. You can even combine multiple of those together, right? Like you can TENS and ice at home. TENS units probably cost 30, $40 for a decent one online. So you combine that with your ice, and now maybe instead of a 60-minute therapeutic window, we open it a little bit more. So I like the strategies that you outlined, and I like even more if we can combine multiple at the same time, just for, a time standpoint, but also maybe a maximizing effective standpoint too. You mentioned the therapeutic window. With all these things, there's a minimum effective dose and there's a maximal effective dose. And I'm trying to get people as close to the maximal effective dose as I can without going over it within their tolerance. So I love those strategies. I think that they definitely play a great role from a physiological standpoint in getting the quad to fire again based on the mechanisms you previously discussed. Modalities are great. Exercise modifications are great. How are you dosing these things, because I think that's ultimately what moves the needle forward. Are you like a 3x10 everything once a day kind of guy, or how do you go about like actually putting together like the exercise component of things?
Yeah, great question. I think especially in the early phase of rehab and with AMI and with range of motion, right? Frequency and volume are two, restoring range of motion and quad activation. So no, it's not enough just contracting your quad like 30, 60 times a day. I usually prescribe more than 500 reps a day throughout the day, for heel pops, quad sets, all that stuff, straight leg raises, and we give our patients an NMES unit that they can use at home, NMES and TENS, both. So they do a lot of volume, and in terms of frequency, 5, 6 times a day. It's a lot of work in the beginning.
It has to be that way though, right? Like, I
Yeah.
think I think a lot of people, they hear ACL injury, they Google the outcomes and they get scared by what they see. And then they search ACL protocols. And the majority of protocols I see are 3 sets of 10, quad set, straight leg raise, heel slide, which we could have a whole podcast about how I feel about the heel slide at some point. And basic exercises like that, but 30 reps once or twice a day. And then we wonder why the outcomes aren't great. Unfortunately, that's not enough based on the amount of muscle inhibition from the neural driven standpoints that you outlined earlier. That's not enough given the poor quality of tissue immediately following surgery that you outlined earlier. So we really need to up the volume significantly in order to get above that. And I don't know about you, but it's gotten to the point for me where some of my patients will literally download like a counter app and they'll just hit their phone to like actually keep count of their reps, or different times in the clinic. Like I'm literally just telling them to do like sets of 100. I've gone away with, the, set of 30 quad set with the 10-second on, 10-second off timer like I originally did. Like I've switched it now to the point where I'm giving them the trigger button and I'm telling them, look, we're going to knock out 100 as long as it takes. We've got to get the numbers up.
Yeah, I agree with you. We do a lot of reps in the clinic, and I tell them because sometimes, of course, it's not realistic for everyone doing, all this work. We have a lot of college athletes, and they're like, I have to school, like contract your quad like all day, like wherever you are. It's yeah, frequency and volume in the beginning is key.
I think high frequency and overall this is low intensity stuff, right? Like quad sets are not the same as 5 rep max barbell back squat. It's not. So I think that's the key. The only time I will adjust it is if we're increasing joint edema. If all of a sudden things are getting pissed off and swollen, that's when we have to back it down slightly. I still want the quad to be active, but I also don't want to create a whole nother problem of pain and swelling and restart that cascade that you outlined before.
Yeah, 100%, because that's going to lead to further inhibition, right? So these are the things that, in terms of rehab, and we're talking now, about the early phase. Our goals are to minimize pain and swelling, right? Restore the range of motion, counter the effects of AMI and improve quad activation, normalize their gait, prevent deconditioning in a way, and educate and build a strong therapeutic alliance with the patient, especially if we haven't seen them before surgery.
I agree with that. And I love the point about therapeutic alliance because there was a time about a year ago where a majority of the patients that were seeing me after ACL surgery had actually gone to other clinics and they didn't have that, what we'll call therapeutic alliance. A lot of them, just got told, okay, you're good enough and you can finish the rest on your own after 2 months, 3 months, 4 months of PT. And then they end up going back to their doctors 6 months out from surgery, 8 months out from surgery with a whole lot of issues that, in my opinion, not all of them, but the majority probably could have been prevented by just addressing the AMI better early on. Because if you don't address it, you end up with a whole lot of people 6 months out from surgery, 8 months out from surgery with 50 to 60% quad index, with patellar pain, with a lot of, well, I can't do this, that, or the other thing, even though everyone says I should be doing it right now. And I think that's where, I mentioned earlier about the poor outcomes from ACL surgery when people get on Google and they're like getting a little terrified by some of the stats. I think that's where a lot of it comes from in today's day and age, is not addressing the quad AMI after surgery, and then all these other secondary and tertiary problems develop off of it, after the patient has left your clinic. And I think that even further emphasizes the point of following up with your patient, not just for the full 9 to 12 month, rehab window, but afterwards, like send them a text once in a while and say, hey, how are you doing? How is your knee felt? Because if it's anything less than good, I probably did something wrong and I should probably change what I'm doing for people in the future so that doesn't happen again.
Yeah, 100%. We know that if left untreated, AMI can promote maladaptive neuroplasticity, right? Like we talked about, changes in the brain, and that can contribute to persistent muscular impairments and compensations down the line. So the risk might be higher, the risk of injury might be higher, right? And I agree with your point, like even after they're done or cleared to go back, just texting them, see how they're doing, either continue with their strength and conditioning program, all that stuff. Another thing that we started doing, and I just started doing, is I have patients coming back even after they are cleared to go back to their sport, and we test them again at 1.5 year or 2 year, the 2 year mark, just to see how they're doing, see their numbers, checking with them.
I think that's a great point as well. And I've done the same thing in the past. I'm curious, usually from a testing standpoint, for the first 3 to 4 months, I am racing to get them as high of a quad index as possible. I know they say, some will say 70% by month 3, some will say 80%. I don't really have a goal in mind other than as high as possible. Like if I can get someone in the 90s, I'm going for the 90s. If I can get them in the 80s, I'm going for the 80s. But the first 3 or 4 months, it's just chasing as much quad as we can get. And I usually test that with a dynamometer, probably the same one you use at 90 degrees and 60 degrees. Quad, open chain, left versus right. And I am specifically looking at the peak force output that the quad has. And I know that there's a lot of other, types of quad type tests that you can conduct with dynamometers, like, RFD, you can do endurance type tests, that sort of thing that way. Does your quad testing tend to be similar to mine early on, or how does it change later on? And what kind of things are you looking for beyond like peak force, if anything?
Yeah, so I mean, in terms of testing, we use the Team Deck in the clinic. That's what you used to. Okay.
Yep.
So we use the same device. We test peak force, like you said, and we also get the torque to body weight number. I agree with you. I try in the first few months to get the quads back and get the index as high as I can. Coming back to your point, everyone is different, right? So rate of adaptation, how they adapt is going to be different in terms of what time. We usually test them at 12 weeks. That's the first test that we do, especially with patellar tendon grafts and quad grafts. With hamstring, we might test them a little earlier, around 8 weeks. But like I said, we see a lot more quad grafts nowadays. So I would say around 12 weeks, that's when we start testing them. So we test them at 12 weeks, and then we test every 4 to 6 weeks. And we adjust our programming based on that, and based on the numbers that we get. In terms of rate of force development, I don't test that with a Team Deck because the sampling frequency is too low. So it doesn't give us great data. We have, coming back to the numbers that we want to see, you mentioned 70%, 80%. Yes, we look at the symmetry, but at the same time, I look at the torque to body weight number that we get, and 2 Newton meters per second is what I usually want to see before they start running. And that's just one test, right, for the quad, which is one of the most important ones, but we want to make sure that they don't have effusion or a lot of effusion, that they have the range of motion is almost symmetrical through the knee flexion. calf strength is there, all that stuff. So for the torque to body weight, we want to see 2 before they start running. And then for return to sports, we go by 3 newton meters per second plus the LSI number, so the symmetry between sides. Yeah, it gives us a lot of information. It has its limitations because it's an isometric test. We don't have an isokinetic device. I think most clinics don't. It's very expensive, right? But I've seen a lot of people hitting 3 and having pretty good symmetry, and they're still struggling a lot with eccentric control or the eccentric RFD numbers that Rachel gets are the asymmetry there is too high. So even if they hit 3, we want to make sure that they don't have a lot of symmetry with the jumping stuff and the test that Rachel does at this point.
On the torque piece too, are you doing like you said you don't have an isokinetic device, so you're calculating the torque based on the isometric value and the length of the moment arm for the quad?
Yeah, so the length of the tibia and their body weight.
Yeah, no, I like it. I like it. And I think that's something too. It's always interesting to see. Generally, I think as the strength increases, as you build a bigger engine, the torque goes up. But sometimes you find 1 or 2 cases that are a little bit more complex than that, right? Where people test really strong, but torque is still down. So it's one of those things that sometimes we need to look beyond the brute strength element. I think I tend to fall under the camp of what I call load the sucker, where I just try and build people a bigger engine. And a lot of times that's what they need, but sometimes we kind of break off into the weeds a little bit more as people need more specific elements. So, maybe we have strength, but we're still, lower on our power side, and we need to actually work on power development instead of just bulking things up and getting them stronger. So I think that the testing element as it is specific to the quad, can certainly help dictate how you spend your time from a rehab setting as well.
100%. And sometimes we get people 6, 7 months out coming to our clinic, right? And they still have issues returning to sport and all that stuff. And they come to me and they say, yeah, they told me I have 90% symmetry and I'm good to go. And we test them, and even the other leg is not as strong as we want it to be. So that's the reason why they're at 90%, because even the other leg is not as strong, right? They might have 2 newton meters per kilo on the non-surgical side too. So we need to work on both and increase their strength and their force output. And when we do that, we see that they start feeling better and everything, cleans up from a kinematic like standpoint.
Yeah, no, I agree. Same thing with on the tin deck is like originally, like when I was testing people, there's not really like the tin deck device itself is meant for like rock climbing, mountain climbing type stuff. So they don't really have like a normative like this is what a 16-year-old's quad strength should be like. So I kind of had to develop that for myself based on patients that I was seeing. And it's really interesting to kind of see where people sit and where people will come in sometimes very late, in the game and where their numbers will test at, right? Like, there's a point when I would have someone come in 6, 7 months out and I do their tin deck and it's like, 110 on the uninvolved and 95 pounds on the involved. And to your point, it's like, okay, good symmetry. But then you stop and think about it and it's like, well, wait a second, they're this far out. Like, they should be, compared to a lot of my other patients, they're in the 160s, 170s, 180s. So why are we so low on both? And I think that there's a lot of interesting discussions that could be had off of that. But I think in short, not just, pushing one leg from an AMI standpoint, but encouraging people to train the other leg as well. Or if they're free of compensation, train both. I think that there's a variety of literature out there that supports training both sides for a little bit of enhancement in motor unit recruitment. I typically see it more common in the shoulder than the leg, but it can certainly be done in the leg as well.
Yeah, 100%. I mean, I focus a lot on single leg stuff throughout the rehab. That doesn't mean that we don't implement any bilateral training, right? Any like we do squats, we do trap bar deadlifts, we do everything. I focus a lot on single leg because of the compensations that we see.
Definitely, definitely. I think that's essential. Pavlos, I feel like we covered a lot of ground today as it relates to AMI and how to really bring a quad back to life after ACL surgery and, why the quad is even inhibited in the first place. Do you have any kind of closing thoughts or closing remarks or anything that we missed today?
No, I think coming back to what we discussed before we started, I think we need to do better at translating research into practice as a profession. In terms of same for it goes same for AMI. Like I think we need to start using all these strategies and modalities that we discussed about today. We have to assume that everyone who comes in after an ACL reconstruction has AMI and treat them that way.
For people who want to find out more about you, where can they find you at? Are you an Instagram guy or
Mostly Instagram at Pavlos Gkikas PT, Pavlos PT.
we'll link to that in the description below, so that way you can just click there as well. Always a pleasure talking with you. I really appreciate your time and everything you shared with us today.
Thanks again for having me and for the content that you put out.